Welcome back to the deep dive. Today we're kicking off something a bit special right here on the main feed.
Yeah, we're calling it the 21st Century Man podcast.
Exactly. We're going to dive into this fantastic book, The 21st Century Man, one chapter at a time, pulling out all the key stuff for you.
And today we're jumping right in with chapter 53. It's titled A Healthy Smile, and it's written by Paul Schulberg, who's a DDS.
A healthy smile, yeah. Super important topic, I think, for confidence, just general health, how you communicate.
Definitely.
And Dr. Schulberg starts with this quote from Mallory Hopkins, which kind of sets the tone. Life is short. Smile while you still have teeth.
Ah, good one. A little blunt, but gets the point across, doesn't it? Don't take them for granted.
Seriously. And right away, the chapter points out, a smile isn't just about teeth. It's this whole facial expression thing.
It's communication, really. Positive communication.
Right. It talks about harmony, the angle of your mouth, seeing a glimpse of healthy teeth, facial symmetry. It's complex.
And, people have been trying to create nice smiles for ages. The chapter mentions going back to, 700 BC.
No way, 700 BC. What were they doing?
Apparently using animal teeth, or even human teeth, held together with gold wire. Primitive stuff.
Wow. Okay, that's dedicated.
But the real foundation for what dentists do now, designing smiles, that comes from the ancient Greeks, the golden ratio.
The golden ratio again. It pops up everywhere.
It really does. It's about that roughly 1 to 1.6 proportion. They use it to balance your facial features with, the size and shape of your teeth. It's still the standard design language today.
Fascinating. So we're going beyond just brushing and flossing here. We're getting into the art and the tech behind and keeping a great smile, all based on this chapter.
That's the plan. We'll unpack what Dr. Schulberg covers, from designing the smile itself to, the everyday maintenance.
Okay, so where does he start with the design aspect? He mentions smile solutions and smile makeovers.
Yeah, and he notes that he actually focused only on that in the last decade of his practice, so it's a real specialty.
And probably not cheap, I'm guessing.
Definitely not. The chapter mentions figures upwards of $15,000 if you're remodeling, say, 8 to 10 teeth.
Ooh, okay.
Which is why, he stresses, consumer education is so important. You need to know what you're getting into. There's a learning curve for dentists, too, apparently.
That makes total sense. So if someone wants to, brighten things up, what are the main ways the chapter suggests?
He highlights 3 main strategies: bleaching or whitening, Invisalign for alignment, and veneers for refacing the teeth.
All right, let's talk whitening first. That seems like the first port of call for a lot of people.
For sure. It's generally the most accessible and cost-effective option. And whiter teeth, well, they tend to make people look a bit younger, right? That's a big draw.
So how does it actually work? Is it just surface stuff?
Not entirely. It's a chemical reaction using peroxides. These actually seep through the enamel, the outer layer, and get to the dentin core underneath. That's where they reduce the discoloration. It also helps with external stains, of course.
Does it work for all types of discoloration?
Not quite equally. The chapter says it's best for yellow to orange type stains.
Okay.
But if you have grayish discoloration, maybe from tetracycline antibiotics when you were a kid, or trauma, or even a high fever during tooth development, those stains are really deep in the dentin. Whitening doesn't do much for those.
That's really good to know. So it's not a magic bullet for everything. What about the different methods, like trays versus lasers?
Right. The chapter covers a few. You've got the custom-made bleaching trays you get from your dentist.
Yeah.
Those are slower. You wear them at home, but they protect the teeth better. And you can use lower strength solutions over a longer time, like maybe 2 weeks or more with a mild carbamide peroxide. The author actually thinks this gives the best long-term results. You might even use an Invisalign tray or retainer sometimes.
Okay, slower, but maybe better long term. What about the in-office stuff? The faster results?
Yeah, the laser treatments or intense light ones, they use that light as a catalyst, basically speeding everything up. You can get 4 to 6 shades lighter in just one visit.
Wow.
But the downside is potential sensitivity. It can be pretty intense, and if it's done too aggressively, you could potentially damage the teeth. Plus, you usually still need to do some follow-up at home.
And whitening strips, the one you buy anywhere.
They have their place. Good for mild stains, touch-ups, that sort of thing. Convenient, but again, not great for those deeper stains. And a big limitation, the chapter points out, is they usually only cover the very front teeth.
So it might look weird further back.
Exactly. For a really natural look, you ideally want to whiten out to the bicuspids, maybe the first 10 upper teeth, the ones that show when you have a big smile, so they blend in.
Gotcha. Okay, so whitening, good start. Know the limits, choose wisely.
Yeah.
What about option 2? Invisalign. That's for straightening, right?
Exactly. Alignment, not color. Invisalign is basically this really sophisticated orthodontic software. It's a CAD/CAM tool,
CAD/CAM.
computer-aided design, computer-aided manufacturing. It was developed mainly for adults who have, say, moderate crowding or misalignment, not typically for kids because their bones are still growing.
How does it work? Is it like invisible braces?
Sort of. The dentist maps out your ideal tooth positions digitally. Then the software calculates all the tiny movements needed step by step, like tenths of a millimeter at a time.
Okay.
And then it designs a whole series of clear plastic retainers or aligners. They get 3D printed. You wear one for about a week, then pop in the next one and so on. Could be 28 trays, maybe more.
That's pretty cool tech.
It is. Been around since the early 2000s, and it can get really great results. But the chapter really stresses that the dentist's experience with the system is key. They have to plan it right.
So who's it good for?
Anyone who's not happy with crooked or crowded teeth, basically. And sometimes just getting things aligned nicely, maybe a bit of whitening, that's all someone needs for a huge improvement. No need for, like, major restorations.
Yeah, I can see that.
It's great for professionals, people in competitive fields maybe, who want to improve their smile, but, discreetly.
Fits right into that 21st century man idea.
Yeah.
Okay, strategy 3. Veneers. What's the deal with those?
Veneers are these super thin shells, usually made of ceramic, sometimes a resin composite. They get bonded right onto the front surface of your tooth.
To kind of reface it.
Exactly, reface it. You can change the shape, the size, the color, much more dramatically than just whitening allows.
This is like putting a new, better-looking enamel layer on.
That's a good way to think about it. It builds on the strength and color of the tooth underneath, but enhances it. And the bonding is crucial.
How does that work? The bond.
They use a mild acid, phosphoric acid, to gently etch the enamel and dentin. It creates these microscopic little textures. Then the bonding resin flows into those and hardens, locking the veneer on super tight. It actually makes both the veneer and the tooth underneath stronger.
Sounds involved. How long does it take?
For a typical smile makeover, maybe 8 or 10 veneers, you're looking at maybe 2 to 4 office visits, and they're usually pretty lengthy appointments. It's meticulous work.
Is there anything faster? The chapter mentions prepless veneers.
Yeah, those are extremely thin veneers, like tenths of a millimeter. The idea is you might need minimal or even no preparation, no grinding down of the natural tooth.
Oh, interesting.
It sounds great, but they require very skilled labs to make them properly, and while it might reduce chair time a bit, it's still a complex process.
Is that a new thing? Prepless?
Well, yes and no. There were early attempts back in the 70s and 80s, kind of like press-on veneers, but they often looked bulky and fake. The newer materials and techniques are way better, allowing for much more natural shapes, but it's still a specialized area. Not every dentist or lab does them well.
Okay, so different tools for different jobs. Whitening, aligning, veneering. The chapter really seems to emphasize technology. CEREC is mentioned.
Yes, CEREC stands for Chairside Economical Restoration of Aesthetic Ceramic. It's a big deal. It's computer-aided tech that lets dentists make ceramic crowns, veneers, other restorations right there in the office.
In one visit.
Often, yes. Especially for crowns.
How's that different from, say, the old way of getting a crown?
Oh, completely different. Traditionally, you'd get the tooth prepped. They'd take this goopy mold.
Ugh, I remember those.
Right. Then they send it off to a lab. You wear a temporary crown for maybe a couple of winks. Then you come back for a second visit to get the permanent one fitted.
And with CEREC.
The dentist preps the tooth, then uses a small digital scanner like a wand to take a 3D image inside your mouth. No goop.
Oh.
Then, right there on computer, they design the crown. That design goes to a milling machine in the office, which carves the crown out of a solid block of ceramic. Then they finish it, maybe stain and glaze it, and bond it in place, all in one appointment, usually.
That sounds way better for the patient.
Huge difference. Faster, more convenient. And the chapter notes that with a skilled dentist, the results can be just as good or even better than lab-made crowns.
So how do you find someone who's really good with CEREC or this kind of tech?
Good question. The advice in the chapter is pretty practical. Ask around. Get referrals from other patients, maybe other dentists or hygienists. Even your regular doctor might know someone.
Okay.
And don't be shy about asking the dentist directly about their experience. How many CEREC restorations have they done? Hundreds. Thousands. That experience counts.
Makes sense. The chapter goes even deeper into tech, right? Talking about advanced imaging and root canals.
Yeah, the 3D imaging, specifically dental CT scans, or CBCT. Cone beam computed tomography.
Sounds fancy.
It is. You mostly find them in specialty imaging centers or really progressive dental offices. It's a massive leap from standard 2D x-rays.
Why is it so much better?
It gives you this complete, detailed 3D picture of your teeth, jaw, bone structure. You can spin the image around on the screen, look at slices from any angle. It's absolutely essential for planning dental implants accurately.
Okay, I see that for implants. But how does it change something like a root canal?
This is where it gets really interesting, and it's a big point in the chapter. For decades, dentists kind of thought the canals inside tooth roots were fairly simple tubes.
Yeah.
Turns out they're not. They're incredibly complex. They branch out, have little side canals, intricate networks, way more complicated than anyone realized from 2D x-rays.
Seriously, not just straight lines.
Not at all. And that's why CBCT is revolutionary for root canals. The endodontist, the specialist, can see that entire 3D maze before they even start working.
Ah, so they know exactly what they're getting into.
Precisely. They can see all the branches, figure out the complexity, and even assess if the tooth is realistically treatable. It leads to much higher success rates.
Why? Because they can clean it all out properly.
Exactly. A lot of past root canal failures happen because dentists just couldn't find or seal off those tiny hidden side canals using the old methods. CBCT lets them see everything. It's completely changed endodontics.
So the takeaway is, if you need a root canal.
Ask if the dentist or specialist uses CBCT imaging. The chapter strongly suggests it. It maximizes your chances of success, and really, it's becoming the standard of care because it's so much more precise.
That's huge. And does all this fancy imaging mean more radiation?
Interestingly, no, not necessarily more overall. The chapter notes that a CBCT scan plus maybe 4 standard bite wing x-rays often involves significantly less radiation exposure than a full set of the older film-based dental x-rays, and you get way more diagnostic information.
Good to know. Okay, let's switch gears a bit. What about protecting the teeth we already have, minimizing damage?
Right. The chapter covers a few key things. First, a knocked out tooth. Dental avulsion.
That sounds like a serious emergency.
It absolutely is a true dental emergency.
It was the first thing you do.
If the tooth is intact, rinse it gently. Saline is best, but water works, and the absolute best thing is to try and put it straight back into the socket immediately.
Yourself, right there.
If you can, yes, gently. If not, don't let it dry out. Put it in a container of whole milk.
Milk, really?
Yes, whole milk helps keep the cells on the root surface alive. Then get to a dentist ASAP. You've got a pretty small window, maybe 20 to 40 minutes, for the best chance of saving it.
Wow. Okay, milk.
Yeah.
Got it. Then what does the dentist do?
They'll clean the socket, clean the tooth, replant it properly, and usually splint it, kind of like wiring it to the teeth next to it for a week or two to keep it stable.
Does it always work?
Not always. It'll need a root canal later, too. Success really depends on whether the periodontal ligament, the tissue that holds the tooth in, heals and reattaches. Maybe 50-50 odds are better, but definitely worth trying to save your own tooth.
Definitely. How about preventing that kind of trauma?
Mouth guards. For any kind of impact sport, doesn't matter if it's contact or not. It's such cheap insurance against knocking out a tooth.
The boil and bite one's okay.
The chapter suggests getting one custom made by your dentist. They fit much better, are more comfortable, so you're more likely to actually wear it. The boil and bite ones often don't fit well and end up staying in the sports bag.
Good point.
Yeah.
What about just stupid things that break teeth, everyday stuff?
Oh, yeah. The chapter lists the usual suspects. Biting down on an unpopped popcorn kernel, chewing ice, hard candy, nuts, finding a bit of bone or shell in your food.
Using your teeth as tools.
Big one. Tearing tape, opening packages. Teeth are strong, but not indestructible. Especially, the chapter notes, if you already have large, older fillings like metal amalgams which don't bond to the tooth structure.
Can those breaks be fixed?
Usually if it's just the crown part of the tooth. But if the fracture goes down into the root, that's much more serious. Could mean losing the tooth.
Anything else that damages teeth?
Yeah.
Like medications.
Absolutely. Dry mouth is a really common side effect from lots of meds, beta blockers, diuretics, antihistamines, many others. And saliva is crucial for protecting your teeth.
Right, washes things away.
Exactly. And it buffers acid. So less saliva means higher risk of decay. Also, the chapter mentions things like tetracycline staining teeth if taken during childhood.
What about fluoride? Good or bad?
Overwhelmingly good. Adding fluoride to municipal water has caused a massive drop in cavities nationwide. It strengthens enamel.
Tell me, you get too much?
You can, usually only from naturally high levels in well water. It might cause some harmless white streaks on the enamel called fluorosis, but it doesn't damage the tooth structure.
Okay, and lastly, under damage, tooth grinding, bruxism.
Yeah, bruxism. It's described as complex and somewhat controversial. Usually happens at night. It's this excessive clenching or grinding.
Wears down the teeth.
Definitely wears down teeth, can strain your jaw muscles, cause TMJ discomfort. Stress is often a big trigger. But sometimes it can be related to how your teeth meet or even certain medications.
How do you stop it?
Well, you don't really stop it easily. The standard treatment is a night guard or occlusal splint.
Like the sports mouth guard.
Similar concept, but designed differently. You wear it at night, it covers the chewing surfaces, it gives the muscles some relief, and critically, the wear happens on the plastic guard instead of your enamel.
So it protects the teeth.
Yes. It protects the teeth from the damage of grinding. But the chapter makes a key point. The night guard itself does not treat or cure the underlying reason you're grinding. It just manages the symptoms, protects the teeth.
That's an important difference. Okay, so that's protection. What if you've already lost a tooth or have gum problems? The chapter covers periodontal work too.
Right. If you're missing one or more teeth, the classic solution is a bridge.
How did that work?
It literally bridges the gap. If you're missing one tooth, you need a 3-unit bridge. They put crowns on the teeth on either side of the gap, and those crowns hold a replacement tooth called a pontic in the middle.
Okay, what are they made of?
Usually ceramic, sometimes with a metal core underneath for strength. All ceramic ones are bonded, metal core ones are cemented.
And the alternative? Implants seem popular now.
Very. The chapter presents implants as a really effective alternative, often the preferred one. It's basically a titanium screw or fixture that's placed surgically into the jawbone to act like a tooth root.
It fuses with the bone.
Yeah, that's the key. Osseointegration. Takes some time to heal and integrate. Then an abutment piece connects the fixture to the final crown that looks like a tooth.
What's the big advantage over a bridge?
The main one is that you don't have to drill down the healthy teeth next to the gap to put crowns on them, like you do for a bridge.
Ah, that's a big deal.
Huge. For a single missing tooth, the chapter basically calls implants the treatment of choice now. They are expensive, yes, but often the total cost isn't much more, or sometimes even less, than a 3-unit bridge when you factor in work on 3 teeth versus 1 implant site.
And technology helps here too, I bet.
Absolutely. That CBCT 3D imaging is crucial for planning exact placement. And they can use CAD/CAM to make surgical guides, often 3D printed, to ensure precision during the surgery.
Who does implants? A regular dentist?
They can, but the chapter suggests oral surgeons and periodontists often have the most extensive training and skill since they specialize in the bone and gum tissues that support the implant.
Makes sense. What about gum issues, like recession?
Yeah, gum recession, where the gum tissue and sometimes bone gets stripped away from the base of the root. Often happens if you have genetically thin gum tissue, a thin biotype. It's a challenge for periodontists.
Then they fix it.
Yes, often quite successfully. They can do grafting procedures, usually involves taking a small piece of connective tissue, often from the roof of your mouth.
Ouch.
It can be sore, yeah. But they use that tissue matrix to basically grow new gum tissue over the exposed root surface. Bone grafting techniques have also gotten much better if needed.
What's the goal? Just cover it up?
The goal is really an undetectable result. Healthy gums, natural contour. The chapter calls it the plastic surgery of dentistry. There are really skilled practitioners out there who can do amazing work.
Okay, wow. We've covered a lot: fixing, replacing, designing. Let's get back to the absolute basics. Daily maintenance. What are the non-negotiables, according to the chapter?
This is where it all starts, right? Preventing decay, or dental caries, cavities.
Caused by?
Bacteria. Living in that sticky film on your teeth, plaque or biofilm. They feed on sugars and refined starches in your diet, produce acid, and that acid just dissolves the tooth structure. It's an endemic problem.
And cavities happen in different spots.
Primarily 2 types. Pit and fissure cavities on the biting surfaces where enamel might not fully fuse. Those can often be prevented with sealants, especially in kids. And then interproximal cavities, the ones between your teeth.
That's the flossing one.
That's the flossing one. Lack of flossing is the main culprit there.
Is chewing gum actually helpful?
The chapter says yes, surprisingly. If you can't brush right after a meal, chewing sugar-free gum can help. It stimulates saliva, washes away debris, reduces plaque. Gum with xylitol is especially good because xylitol actually inhibits the main cavity-causing bacteria, plus helps with bad breath.
Okay. Brushing basics. Anything new there?
Brush after meals if you can. Get a portable brush maybe. Electric brushes are great sonic or rotary kind of user preference. The chapter recommends a soft brush head though. Sonic can feel a bit aggressive to some.
A long technique.
Most electrics have a 2-minute timer, which is good. Gentle pressure, cover all the surfaces methodically. Twice a day is usually sufficient for most people. And change your brush head every 3 months or so when it looks worn.
Toothpaste.
Use one with fluoride. Sodium fluoride is generally preferred over stannous fluoride, which can sometimes cause staining.
And flossing, the big one, called non-negotiable.
Absolutely critical. It's the only way to clean those surfaces between the teeth where the brush just can't reach.
Any tips on technique? It can be awkward.
Teflon-coated floss, like Glide, often slides easier. The key, the chapter emphasizes, is understanding the anatomy. You need to gently curve the floss around the base of each tooth at the gum line, go slightly below the gum line if you can without forcing it, and clean both sides of that little space between the teeth.
So not just popping it in and out.
No, definitely not. You've got 2 surfaces to clean in each gap. There are also floss aids, like those little plastic picks with floss. Glide Gum Care Floss picks are mentioned, which some people find much easier and more convenient.
How often? After every meal?
Ideally, yes. But the chapter also cautions about overflossing or using bad technique, which can actually damage the toothpaste or gums. Best to work with your hygienist or dentist to get the technique right.
What about tongue scraping?
Highly recommended in the chapter, especially in the morning. Removes that coating of anaerobic bacteria that builds up overnight on your tongue.
The stuff that causes bad breath.
Exactly. Volatile sulfur compounds. Tongue scraping is very effective for that. Daily habit.
And mouthwashes, do they help?
Most over-the-counter ones. The chapter says they have little real effect on the bacteria. At best, they just mask odor temporarily. Prescription ones, like chlorhexidine, can suppress bacteria but often cause significant tooth staining. And sometimes persistent bad breath isn't just an oral hygiene issue. It could be linked to systemic conditions, like diabetes.
This feels like a good place for that strong warning you mentioned earlier.
It is. The chapter states it very clearly. Only brush the teeth you want to keep. Brushing and flossing are non-negotiable. It really drives home that you need to pay attention to all those little nooks and crannies. The alternative is costly repairs, gum disease, periodontal bills.
Yeah, that lands hard. And you mentioned a link to overall health beyond just the mouth.
This is probably the most crucial takeaway, honestly. The source points out that bacteria from plaque, specifically mentioning strep viridans, can actually get into the bloodstream and cause endocarditis, a really serious infection of the heart lining. And other bacteria found in that oral biofilm, like Fusobacterium, have even been linked to certain types of cancer. So neglecting your oral hygiene isn't just about cavities or losing teeth. It has potentially severe systemic health implications.
That really puts the daily grind of brushing and flossing into perspective. It's not trivial.
Not at all. It's fundamental health maintenance. The chapter also briefly mentions the book's website, www.the21stcenturyman.com, for more info, and touches on dental insurance.
What's the gist on insurance?
Most people get some through work. It helps cover essential stuff but benefits very wildly. Know what your plan covers, but the author kind of implies you often just break even on the premiums versus the routine care you get back.
Right. And then the final simple advice from the source.
Just make life easy. Brush, floss, enjoy, smile.
Perfect summary. Okay, so let's wrap this up. What this deep dive into Chapter 53 of the 21st Century Man shows us is, well, a lot.
It really covers the waterfront. From the history and aesthetics of a smile to the incredible modern tech like CEREC and CBCT that's changing treatments like crowns and root canals.
Yeah, and practical stuff like handling emergencies, minimizing damage from grinding or accidents, and understanding options like bridges, implants, and grafting.
But underpinning it all is that absolute necessity of the basics. Brushing and flossing correctly and consistently. Not just for appearance, but for fundamental systemic health.
I found this chapter incredibly valuable. It explains the why behind dental care, shows you the amazing possibilities of modern dentistry, but constantly reinforces that those simple daily habits are where it starts.
It's a really great example of the kind of practical, well-structured knowledge you find throughout the 21st Century Man.
Absolutely. We've really only skimmed the surface here today. I strongly encourage you, if this interested you, to grab a copy of the book and read this chapter and all the others for yourself. So many actionable insights.
You definitely won't regret it. It's packed with useful information.
So that brings us to the end of our deep dive into Chapter 53, A Healthy Smile. Thanks so much for joining us as we explored the source material.
My pleasure. And next time, right here on the 21st Century Man podcast, we're moving on to Chapter 54. The topic, protecting your skin.
Another crucial one for health and appearance. We hope you'll join us for that next deep dive.